Dear colleagues, dear friends, it's a great pleasure to welcome you to this new podcast of HEHAT. This is part of the HEHAT learning activity. My name is Cedric Hermans. I'm based in Brussels, Belgium. This podcast will be focused on the diagnosis and challenging diagnosis of von Willebrand disease. To run this podcast, I will have two experts in the field, Luciano Baronciani from Milano and Omid Seidizadeh, also from Milan. Dear colleagues, hello to you.
Hello, and thank you for having us here today.
Thank you for having me as well.
Thank you, and thank you to you for taking part in this podcast. So you prepared recently a very nice presentation about von Willebrand disease. So maybe Luciano, maybe you could summarize concisely what are the key messages, the key guidelines that have recently been published about the diagnosis of von Willebrand disease.
Okay, I will try. I just want to try to make a comment regarding the fact that the viewer would certainly notice a strong difference between the first presentation regarding the guidelines and the second presentation, which present a very complicated case. And I want to stress the fact that the guideline has been prepared to deal with what are the most common form of von Willebrand disease, because as you see in the second presentation, it may happen that things are more complicated than what we usually expect them. I mean, we can not only have type 1, type 3, and 2A, 2B, 2M, and 2N, which are already a complicated situation, but sometimes things are even more complicated. So I believe that the panel of the new joint guideline try to minimize the aspect, otherwise would have been such a long document to go through in detail, and try to focus on the main classification, avoiding to go through all the peculiar situation that may happen in this disease. And I was looking also at the presentation of Professor Pevandi. She was pointing out that basically the recommendation that the panel made are mainly just suggestion, but in 3 cases they were made a strong recommendation. And I think one very important one was about the classification of type 1 or low von Willebrand disease. I think it is very clear that whenever a patient has an abnormal bleeding and present value that are borderline or just below 50%, and we mean von Willebrand factor antigen or von Willebrand factor platelet-dependent activity, or even von Willebrand factor collagen binding, we should consider them as affected as type 1, of course, if the ratio of the activity to the antigen is normal. And another important aspect that I do recommend is the use of the STH-BAT in alternative to any other questionnaire in order to establish if the patient, which is the primary care evaluation, should or should not perform further investigation. And by further investigation, they means the 3 assays, the main 3 assays, which are the factor VIII, von Willebrand factor VIII coagulant activity, the von Willebrand factor antigen concentration, and the histocytic factor, or I should say, the platelet-dependent von Willebrand factor activity that nowadays can be tested using also other assays, not just the histocytic factor. Actually, this is one of the points, even though this recommendation is not a recommendation, it's just a suggestion. They do suggest to use new assay in comparison to the old one. I guess I could go on for a bit, but maybe you have some point that you would like to focus, since the guideline has 11 points. I don't want to start to list all of them. There is any particular issue that you think could be complicated or that should be clarified further?
Well, maybe Luciano, I think you clearly emphasize the importance of using algorithms to make the diagnosis of von Willebrand disease. So could you comment on this, the importance of following the algorithm that have been proposed in the latest guidelines?
Okay, so I believe that what is important is that laboratory that are not dealing with von Willebrand disease as expert should be able to identify the potential patient who is affected with von Willebrand disease. But I think sometimes following algorithm, it can be difficult, for example, even to establish if we are looking at type 1 or a type 2, or actually in the WIN study, they were showing that sometimes even the difference between a type 1 and a type 3 can be complicated, because sometimes type 1 can be so severe that they are similar to type 3. So I think algorithm should help the first step on the process of diagnosis. But I also believe that once, if I am not an expert laboratory, once I establish that the patient has von Willebrand disease, I should try to refer to center with, let's say, more experience. Because as Omid will show you on some data, sometimes even among very well classified type 2, you can find out that following the algorithm, you will come out with a diagnosis of type 1. So I think those are really the elementary step in order to try to identify which type of von Willebrand disease the patient has. But I think really the main point is, does my patient have von Willebrand disease? If yes, maybe we can ask collaboration to other center, send some sample, could be either plasma or DNA, and try to confirm the diagnosis, and especially try to establish the correct diagnosis.
Another question, you also emphasized in your presentation a specific type, which is type 1C. So could you elaborate a little bit on, what are the key features of type 1C?
Yes, definitely. I had a problem in the past with type 1C. Talking with a colleague working on the Zimmermann program, I was asking, how can I identify them? And the answer was often, well, they have an increased clearance, which is true, but many, as Omid will show, many variants in von Willebrand diseases, mainly type 2 variant have an increased clearance. The point is, and I recognize this aspect, if we have a type 1, which means is a patient that has a ratio activity to antigen which is normal, it is important to recognize if this disease, this form of von Willebrand disease, is due to an increased clearance. Because this is important, because DDVP maybe will not be the first choice for this patient if he's going to respond at first to the treatment with this drug, but then it cannot rely on the value because its von Willebrand factor is moved very quickly. So basically, 1C is a type 1 who the main cause is due to an enhanced clearance. And as the panel report, it should be classified so that the physician may know which is the best way to treat the patient when he's in need.
Thank you. Let's now move to the type 2. So we know that there are different types 2, and sometimes it's difficult to identify which specific type 2 the patients have. So in your view, and very quickly, what would be critical to do to establish whether the patient has a type 2A, 2B, 2M? What's critical, shortly?
Well, for sure, the von Willebrand factor multimer analysis, which now has also a version which is commercialized and can be used in many laboratories. Anyway, in alternative, of course, it would be the collagen binding activity and the ratio of collagen binding activity to the antigen, which will give us some idea about the loss of high molecular weight multimer, typical of type 2A and typical of part of type 2B. Type 2M is the most, let's say, complicated, but I should say that if the von Willebrand factor activity, the platelet-dependent activity has been measured correctly, and the ratio with the antigen is reduced, the fact that you may have a normal collagen binding to antigen ratio should suggest a diagnosis of type 2M. And of course, RIPA, which is not commercially available, it's the key sometimes to discern if you are looking at type 2A or a type 2B patient.
Thank you. We won't have time to go in details in part 2 of this module about von Willebrand disease, but what you made there is that you shared several cases and you showed how all the tests could lead to a final diagnosis. Is there any specific comments? So I invite our audience to watch this part of the program to get the full picture, but are there any specific remarks or messages, take-home messages that you would like to share regarding these cases?
Well, yes, that sometimes, so we are talking about the second presentation, the one regarding the complicated von Willebrand disease diagnosis. Definitely, that is a diagnosis that was obtained by studying the family. Sometimes it's very difficult to understand if we are looking at a dominant disease, a dominant form of the disease, a resistant form of the disease. And I believe that to investigate not just the patient, but once the patient is identified, also to investigate what we expect to be the obligated carrier or any relatives may really help to understand what's really going on, because sometimes things are more complicated than what we may believe starting with the basic test.
Thank you. Maybe what we could do now is to move to the last part presented by Omid. Omid, are you with us?
Yes.
So what you did, I think it's a very nice presentation too. You tried to identify some highly specific aspects about von Willebrand disease that we should certainly take into account. So the first one is a limitation in the ristocetin-dependent cofactor activity assay. So could you elaborate a little bit on this?
Definitely. So the first point I would like to emphasize is that when I wanted to do a literature review to choose the most proper and highly advanced paper for the von Willebrand disease, it was quite difficult job because we had many advanced paper and a lot of advance has been done for von Willebrand disease diagnosis, pathophysiology, and also treatment. But this few studies that I chose was mainly regarding different aspects of von Willebrand disease. For example, the first study you mentioned about the limitation of using rhesuscin cofactor activity for the diagnosis of von Willebrand disease was published from Zimmerman. And in this study, they showed that for patients that were suspected of having a type 1 or low von Willebrand factor levels, they found a difference between von Willebrand factor antigen and rhesuscin cofactor activity. And by doing further investigation using alternative assay, so-called GP1BM, they found that in this special population, which they were 82 subjects, antigen was normal, whereas rhesuscin cofactor was abnormal, mainly reduced, and also the GP1BM showing a normal result. So this was very critical to not making overdiagnosis of von Willebrand disease, because if we use only rhesuscin cofactor in our lab, that may create overdiagnosis of healthy population, mainly due to polymorphism at position 1472, aspartic acid to histidine. Basically, this is the common polymorphism. Around 10 to 15% of the population have this polymorphism, especially in Black African Americans, which create a problem of resuscitating to bind to von Willebrand factor, which is not associated with bleeding. This is just a false a positive test.
This is interesting. You also clearly emphasize the fact that patients with low von Willebrand also experience significant bleeding phenotype. So this is important, but I would like to move to another aspect, and I know that you published on this, is the von Willebrand factor activity antigen ratio, that using this ratio could have some limitation, especially when trying to identify the right cutoff. Could you elaborate on this a little bit?
Definitely. So in this study, we used a large cohort of 321 patients, well characterized for type 2 von Willebrand disease. And historically, were used to use a cutoff ratio of 0.6 to make a differential diagnosis of type 1 with normal ratio versus type 2 with abnormal ratio. And indeed, when we used this cutoff of 0.6, we had 54 patients were characterized to have type 2 that had a ratio over 0.6. So, and then when we used a cutoff of 0.7, at least 34 cases of type 2 were misdiagnosed as type 1. So what we here try to emphasize on that, you should not always rely on this cutoff, but if you have access to further laboratory tests such as multimer analysis, collagen binding, or genetic study, this would help to make the correct diagnosis of this group of patients.
Thank you. I think this is a very important piece of information. Another one, and I think you were involved in this great study that looked at the development of inhibitor in patients with type 3 von Willebrand disease. And if I'm correct, that study was published earlier this year. A huge population, more than 200 patients with type 3, which is quite unusual. So what were the main conclusions of that study?
Well, actually, this study was, as you mentioned, the largest cohort of type 3 von Willebrand disease from Europe and from Iran. And they tried to investigate the prevalence of inhibitor development in patients with type 3. And by investigating this large cohort, they found that about 8.5% of patients do have anti-von Willebrand factor antibodies. And in 6% of this population, they have inhibitor. It means that they have neutralizing antibody. And this is quite important because we needed a large cohort of type 3 to establish this prevalence of inhibitor. And they nicely showed that mainly those who developed inhibitor were homozygous for null allele. Basically, out of 14 patients, 11 had homozygous null allele for von Willebrand factor mutation.
Thank you. And maybe a last topic that we could address together, because you have spent a lot of time and energy looking at this, which is the enhanced clearance of von Willebrand factor in type 1 and type 2. So you have been quite productive scientifically in this area. So what would be your key messages for our audience regarding, the importance of clearance and how it could be affected by the type or subtype of von Willebrand disease?
Well, originally, the idea of enhanced von Willebrand factor clearance was developed for type 1 von Willebrand disease. And indeed, if we look at the literature, most of publications deal with type 1. Whereas in this study, we were also interested to look at type 2 to see whether we have enhanced clearance or not. And so we had this large cohort of over 200 type 2 von Willebrand disease and 50 type 1. And by using a cutoff of 1.6 for 4-peptide to antigen ratio, we found that enhanced clearance is indeed mostly prevalent in type 2. Interestingly, we found 80% of type 2 have enhanced clearance, whereas this phenomenon was observed only in 1/3 of type 1. So the key message here was that the enhanced clearance is not limited to type 1, and indeed it is more frequent in type 2. And also we found that over 65 different mutations are associated with a shorter half-life of von Willebrand factor, which might be useful, especially for clinicians when they do not have access to DDAVP trial. Maybe by knowing the mutation could help to have an idea whether DDAVP could be a good therapy for patient or not.
Thank you, Omid. So, well, I think we are close to the end of this podcast. I would like to thank both of you for providing us with a flavor of your three great presentations that really provide a good overview of the recent advances in not only the guidelines, but also some diagnostic challenges for Willebrand disease. So I hope you all enjoyed this podcast, and I would invite you to watch the entire program, the three presentation lectures that are available on the EHAT educational platform. Thank you to both of you, and I wish you a great day or afternoon. Bye-bye.
Thank you. Bye.
Thank you.